Hello, my name is Jason Aldred, MD. I'm a board certified neurologist at Selkirk Neurology and Inland Northwest Research in Spokane, Washington. Hallucinations, I wanted to talk briefly about that. Hallucinations were not commonly seen in the randomized clinical trial or really in our 52-week open label extension study. And I took part in both of those. But hallucinations can occur, and we're using Vyalev on a much broader real world population for people with idiopathic Parkinson's disease now. And they'll be on other medications that perhaps maybe we didn't allow in the study. They will have more mild cognitive impairment, more moderate, severe cognitive impairment, sometimes dementia with good caregiver support. And so their motor symptoms may very much need to be treated with foslevodopa, but they may have a lower threshold for hallucinations. And so this can be worked around. Often hallucinations occur more in the evening, or they can occur if the dose is lowered. Or what I would advise first and foremost probably is migration over to monotherapy, meaning that using Vyalev for the only medication for Parkinson's motor symptoms. And the key thing I found is if patients are having hallucinations on Vyalev, dopamine agonists are very likely involved in this. So removal, gradually weaning down a dopamine agonist over time and slightly increasing the dose of Vyalev can be highly effective to eliminate hallucinations or reduce their severity and make them manageable if a person's already had hallucinations prior to starting. And the other advantage that I've found is that because we're able to fine-tune the dose of levodopa for Vyalev, hallucinations are able to be, in some situations, not quite as episodically tied to the medication dosing. With oral levodopa, when the medication kicks in, the motor symptoms will improve, but also it can, at times, correlate with a spike in hallucinations or disorientation, things like that, that we don't usually see typically with levodopa in its routine use in earlier Parkinson's, but more advanced Parkinson's where hallucinations occur as part of the disease process. Certainly, you can see that more. So, what I'm saying here is that with the actual even subcutaneous delivery of Vyalev, the hallucinations can in some ways maybe be a little bit more predictably estimated as to what the medicine effect will be. So if you have them at a certain level, lowering the dose gradually, and then further and further could, and in my experience has, resulted in less hallucinations for patients. If a person is experiencing what we call sundowning, kind of the evening worsening of hallucinations, confusions, things like that, delusional thinking, reduction of Vyalev to 50% or even 25% of the daytime dose can often be highly effective and still often allow them to sleep better through the night. And lastly, not my primary choice, but if needed, Vyalev can be discontinued overnight if nighttime symptoms are bothersome, and then simply just resume the next morning. Quickly as well, dosing dyskinesia. There's a lot of material out there about a dosing guide. I personally use the dosing guide online for vyalevcalculator.com. But the dosing of Vyalev, it's normal, not unexpected or surprising to have to make some dosing changes. Vyalev is meant to replace oral levodopa compounds and COMT inhibitors. So first replacing that is recommended, and then with that you will sometimes see more off time or more dyskinesia. You're interacting here. You're making a pretty big transition. The drug delivery goes from the skin to the blood in about 2 hours. You get usually your new normal level. So using the high level, using the low level. If you have a little more off time, just go up the higher dose. If you're having more dyskinesia, go into the lower dose. That can be helpful as well. And so that's really meant to be changed a couple of times. The average time to change or time to get to the 12-week endpoint dosing of Vyalev in the studies was about one to two visits. Usually not more than three. But the more fragile the person is, in my experience, the more frequently they take levodopa, the higher doses. Those patients are going to, probably require. They're going to experience as side effects more dyskinesia, maybe more off time, things like that, as you're making adjustments and. The lower dose patients, usually it's not quite as difficult, but everyone's a bit different there, and that's it. I mean, the adverse events are always on a doctor's mind or a clinician's mind when they're starting these medications, but it's like riding a bicycle. It's intimidating for a little while until you really start to do this. And once you get started, you start to get confidence and you realize that you can, navigate around the neighborhood of Parkinson's a bit better. And then once you see patients do well with this, you recognize the adverse events for what they are. I feel very comfortable disclosing adverse events to patients. In fact, I actively bring them to them before we start, and I tell them all these things. And the reason why I do that is because just like riding a bike, the joy of taking off and seeing your patients do so well, and then seeing how much they improve with motor symptoms, and then seeing how they individually learn how to tackle the adverse events that can be experienced and in most cases are inevitable, how those are minimal and don't lead to discontinuation in the vast majority of my patients. And I think ultimately for most patients, I believe that right now we're in a nascent phase for Vyalev, where doctors and patients are just starting to try this out, and it's a lot to learn, and I see only possibilities moving on.